Of the SBI Summer Series. This is a panel discussion, as many of you know. It's put on by the Society of Breast Imaging Social Media Committee, and we discuss current topics that are relevant to breast imagers, patients, providers, students. I'm Mitfa Patel. I am going to be the moderator today. I'm a breast imaging radiologist from OSU, and we are going to be talking today about all things Tomo. So Tomo is short for tomosynthesis, as many of you know, which is also known as 3D mammography for patients out there. This is a relatively new technique, probably within the last 10 years. And, new technology is always really exciting, but it is not without challenges. And so I think it's really helpful to discuss practical use and some, tips that we can share. And I'm really excited to have this panel here today so we can talk about tomosynthesis and some of the new advances in that. So with that, let's do an introduction. Maybe we can go to my over here, Rachel.
All right. Hi, everybody. Great to be here tonight. My name is Rachel Pricer. I'm a breast imager. I've been in Iowa for all of my real career after training in private practice. And most recently, I took on the role of Director of Breast Imaging for Mercy One Northeast Iowa. It's great to be here.
Yeah, welcome. How about down here, Matt? Oh, I'm sorry, Nina.
Ladies first.
Nina.
I don't know whether we were going in a circle.
Ladies first. No, ladies first. Nina.
All right. Hi, I'm Nina Vinkoff. I am at Northwell Health, which is in New York, and I am the chief for breast imaging there for our health system, as well as the vice chair of our department for patient experience.
Okay, welcome, Nina. And Matt.
Hey everyone, Matt Miller. I'm a breast imager in Pittsburgh at Allegheny Health Network. I also help run the residency program as Associate Residency Program Director.
Okay, great. Okay, so we have a really great panel today. Please, if anybody is joining live, feel free to ask questions or comments, post comments, and we can try to get to those as we discuss. And if you're watching this on a recording, we'll try to check in and answer some questions if you post them as well. So first of all, we're going to just talk about, in general, tomosynthesis. Tomosynthesis was introduced in 2011, and it was pretty quickly adopted because it reduced recall rates and it also increased cancer detection rates. So a lot of insurance companies really were on board in covering this modality, and patients also were interested. So my first question to everybody is your practice 100% tomosynthesis, meaning is each site capable of tomosynthesis, and do you utilize it on all patients? And that's open to anybody.
Okay, I'll start. So my current practice is 100% tomosynthesis every patient, every exam, every site. We have multiple sites. But I did experience a practice where we had one of our 8 machines Tomo when I started. And we went through that transition of, basically doing only screens or only, conventional to Tomo, and it was rough. It was really rough, especially before we were completely through that transition, because you'd have people who didn't know what Tomo was, or they would get Tomo one year but not the other. And at one point we had a mixed shop as far as vendors are concerned, and some of them could do Tomo diagnostics and some of them couldn't. So it was an interesting and frustrating time.
Yeah. Nina?
We are all Tomo, but I've also been through some of that interesting transition. So I'm in my position here at Northwell for 7 years. Prior to that, I was actually in private practice for about 16 years. And in the private practices where I worked before I came here, it was in that period of time that the transition to Tomo was going on. So this is like in the 2012, 2013. And back then I got to work in places, or it wasn't necessarily a positive thing, where we were charging people for Tomo as sort of an add-on service. And then luckily, when I came to the place where I am now, we do not charge for Tomo as an add-on service. And we're able to offer Tomo as standard of care. So I've seen it both ways. And I totally agree with you, Rachel. It is hard to work in a place where some of the cases are Tomo, and where maybe last year's was and this year's isn't, and maybe next year's won't be. That's a tough environment to work in. I think I'm a big proponent of, if you're going to do it everywhere, do it every machine, do it every office, do it every patient if you can. It's better, I think, for the patients, and it's much easier for the radiologists, I think.
Yeah, I've heard of places where, people try to send certain patients, to one site, or they try to redo exams, and so it is very difficult when it's not the same at each site. How about you, Matt?
So where I'm currently at Allegheny Health Network, we have 100% Tomo throughout the system. Every site can run the gamut of Tomo biopsies, Tomo diagnostic, Tomo screening, synthetics, which we're going to talk about. I have an interesting perspective, because when I was training at West Virginia University, my first year of residency was the first year that they got tomosynthesis. And I remember it being a big thing. I didn't really know what it was because I was still trying to figure out how to log into the computer, right? And so I just remember people kept talking about 3D mammography, tomosynthesis. It's a big thing. And so I got to kind of see the evolution of how it was kind of a fancy new toy, and minority of patients were getting tomosynthesis, and then by the time I was a senior resident in the fellowship, it was ubiquitous throughout WVU, the breast center. And then I came to Allegheny Health Network, and most of the sites had tomosynthesis, but there were, kind of like you, Rachel, there were a few sites that still, they hadn't updated the machines, and so they could do Tomo screens, but they couldn't do Tomo diagnostics. So I'd find a Tomo finding, and they'd be at this site, and I couldn't do a spot Tomo. I would have to do a spot compression, and not without, I'd have to do a full Tomo again, and it was a headache. But luckily and thankfully, within the first couple of months of me being here, we were able to upgrade. I like to think, this, whatever, but I pounded the table for it at early meetings. Who's this new guy? And I was like, no, we have to change this. We have to change this. And I think it was already rolling down the pike before I got here. But
you can take credit.
As soon as it changes the workflow. It completely changes the workflow if you have kind of heterogeneity throughout your system.
Mm-hmm.
One site we can do Tomo biopsy, and the other site we couldn't, and it was.
It sounds like. Yeah. Oh, we have a question. So, how did your system make the jump to going to all 3D, even though some insurance companies don't cover it? And this might be different from state to state, which is nice that we have people in different areas. Does anybody have a practice where Tomo is not covered?
Wow.
So
So
I know that Ohio, because we border Ohio.
I do.
Wow.
So, and this is difficult. Yeah, go ahead.
Let me say one thing. Getting back to me being in residency, when tomosynthesis was adapted, WVU had basically the largest breast center in the state. At least academic. It was the only academic breast center in the state. And when tomosynthesis, it was the first site that got tomosynthesis adapted. Our section chief, Ginger Lane, who, if she's watching, shout out to you, Dr. Lane. She actually was proactive in lobbying with politicians and insurance companies, basically getting them on the phone. I remember how engaged she was in making sure that it got covered early on. And so that was, she kind of was proactive in making sure that it was covered before it became ubiquitous in our state.
So I need to give a shout out also. In New York, the Como laws basically allow everybody to have Tomo, but a lot of that work was done by somebody in my department, Dr. Bonnie Litvak, who's actually now has a position in advocacy at the ACR. She was up there at Albany fighting for this. So Bonnie, if you're listening, thank you. All of New York.
And out shout outs, I love it.
All of New York thanks you. But yeah, we have great laws in New York where we don't have to worry about that. Thank goodness.
And we are unfortunately in that position where some of our patients, it's not covered by the insurance company. So the way that we handle it right now is that our technologists have a list of the insurance companies that pretty much cover it. And if the patient unfortunately is on one of those plans that it's not covered, we let them know approximately the additional cost, and they can make the choice to not do Tomo. And honestly, it doesn't happen very often. Most insurance companies are covering Tomo, and I think that that's because it actually saves them money in the long run, because there's a decreased recall rate. But Similar to what you guys are describing, we have breast radiologists in Ohio. I know that Dr. Annie Brown from University of Cincinnati has done work, and I might be missing somebody else from that region, but have really lobbied. And we also are going to start getting it covered, actually supplemental imaging covered. So MR and our AVAS. And I believe that starts next year, but I'm not exactly, I don't have the exact date. But, great advocacy work from breast radiologists. It's really important work that we do, that breast radiologists do. I don't personally have, I haven't done that myself, but I'm really thankful for the radiologists who spend time and make sure that they are advocating for our patients. Rachel, do you have any experience with patients not having coverage?
Yes. So when I first started as an attending radiologist, there was almost no coverage for Tomo. And so I would say I went from a university system and fellowship where we just did it for everyone and didn't charge them to, private practice where if it's not getting paid for, it doesn't get done. And so we didn't even fully book our one Tomo machine when I first started. And we did get improved coverage about a year or two into my early days, and that significantly helped with uptake. I would say about 93% of the insurance companies in our market are now covering it, but to variable degrees. And so we have a patient cost estimator line that we give out to our patients so they can have their insurance run on their plan and know what it's going to cost. And then depending on what it is, if the patient's like, I just absolutely cannot pay that, but I'm looking, and the tech is having this conversation with them, and the techs kind of know. They know if it's a really busy mammogram and if it's going to be really, really important. They might come back and say, hey, could you take a look at this? And if it's one of these things where I see a finding or I know they're going to get a call back, I might say, you know what, we might be able to get you to save you that call back if we have Tomo. If you don't have Tomo, I guarantee you're coming back, and that's going to be more expensive in the long run. So we try to kind of manage it that way, but it's tough. And the state of Iowa, most of our supplemental stuff is not covered, and that's a big legislative priority for a lot of our advocacy groups this next cycle, because I spend most of my day having those conversations with patients at least once or twice a day.
And then once you get it covered, then you got to work on cost sharing.
Yes.
It's not enough to have it covered. I mean, in most places, like a wellness visit is fine. And there's probably not going to be cost sharing once you get it covered. But what are you going to do now if you want to use Tomo during the diagnostic stuff, which there might actually be cost sharing on for the patient? There's a lot of levels of complexity in, that people need to fight for, state by state, which is just so crazy.
Yeah, it's crazy. I find it very frustrating in Ohio that screening is covered, but diagnostic isn't.
Yeah.
And, and I'm not just talking about a patient that has a palpable finding, but a callback that we do. And we know that, the majority of callbacks it's a screening study. So it doesn't mean that there is cancer or that it needs a biopsy. We just need to look at it again. And unfortunately, the patients have to pay a lot out of pocket for that. And it's frustrating. So a lot more advocacy work to be done in Ohio. Okay, so the next topic I'd like to move on to is synthetic mammography. With the addition of tomosynthesis, there was added radiation to the patient. And so as a result, vendors developed synthetic mammography, which basically utilizes those tomosynthesis images and forms this like a similar image that is equivalent to the 2D exposure. The FDA has approved it, and they and so you can actually replace your 2D exposure with the synthetic image if you have the technology at your place. So my first question is, does your practice utilize synthetic mammography? Has it replaced 2D mammography? And do you use it for screens or diagnostics or both?
So we use it. We're 100% synthetic. We actually first started running Seaview. We're Hologic, so we were running Seaview at that time in 2016, and we ran it for a year alongside. So basically we were doing that, what Hologic calls combo HD, right? So you're doing both. And we ran it for a year, partially because people wanted to get used to the synthetic, but also because people made the argument to me that they were going to want to have a comparison when we finally switched. Because I said, I don't think I'm going to want to do this for more than a year, but we ran it for a year. And at the end of a year, I just ripped the Band-Aid off and said, that's it. We're not going to keep shooting the 2D. We're just going to do the 3D. So since 2017, we have been 100% synthetic.
So we've had synthetics for many years. And I think the first generation synthetics, and we ran it probably maybe for 2 years, and we kept on saying we weren't happy with them. But the newer generation of synthetics, we were happier with. And so that's when we started sort of dropping our 2Ds. I don't know whether anybody else has any experience with first generation or the earlier synthetics versus the newer ones, and what people think about that as well.
I agree completely. I think that the newer generation ones, you almost can't tell, but the first generation, you could tell. And I mean, just anecdotally, I had a bunch of cases. I kept a little log of like, ooh, I don't, because for a while when we were still a mixed shop of 2 different vendors, we were doing, one of our vendors was not approved for synthetic mammography at the time. And so we were doing both of them and kind of looking at them side by side, but we were still doing the 2D because we didn't want to have a differential in service in that way. And yeah, it was tough. There were some calcifications that were missed. There was motion that was missed. Some really extremely dense breast tissue. I felt like I just could not, tell which way was even up on some of those earlier synthetic ones, and I did not feel comfortable with them at all. And to contrast that to like the latest and greatest that our current vendor is putting out, and if I didn't know better, I would think I was looking at a real 2D. So I feel much more comfortable in that arena.
So you guys use it. It just took a little bit longer.
Yeah.
To. How about you, Matt?
We the only time that we use a combo 2D 3D is, and this was kind of a holdover from, it was kind of a, you're negotiating, different people have different opinions and whatnot. And so when we first adopted a few years ago, it was basically, I think when I started here at AHN, when we adopted the 2D, just the 2D, or just the synthetic, and with Tomo, one of the concessions that we made to the people who are against dropping the 2D completely was, we'll still do the combo for baselines. And we're still doing that to this day. It hasn't been revisited since we did that. I don't know, it just hasn't been a topic on our list. So, we have the second generation synthetic views, and we do that for everyone who comes in that has had a prior. But if it's a baseline exam, we still do the combo 2D, 3D. And the reason for that was it made people feel more comfortable at least having a baseline 2D to compare to in the future. I would be in favor of doing 100% synthetic. But again, that was just kind of one of the concessions in the negotiation.
Yeah. I mean, I did keep an eye on all of our stats, not just the cancer detection rate, although that's obviously the thing that comes most to mind, especially when you're thinking that maybe we're missing stuff, but all of it, our biopsy rates, and we did not see a lot of difference. I will say that anecdotally, it felt like we were doing less magnification views for calcifications. But when you actually go back and look at the stats, like the amount of DCIS that we found isn't any different. So I don't know. And now it's been such a long time that I think if anybody had to look at 2D, we would probably have a horrible year of 1 million callbacks, because
So
everyone would be seeing all the stuff that they hadn't been seeing for the past 6 years, and we probably have a horrible time.
It sounds like everybody had a little bit of a different experiences. Like Nina, you said you ripped the Band-Aid off, and you guys all went there. And then Matt, you had some concessions for people who maybe wanted to hold on to that 2D. We had a comment below that said that they had changed to synthetics, and then didn't feel comfortable, couldn't see calcifications, and so went back to the combo. And I think that's always really hard, right? When you try new technology and you sort of fumble or a little bit. You really always want that new technology to be successful so that people have confidence and you can go forward. I think when I try to introduce some new things, I try to a little bit cherry pick some cases so that radiologists feel comfortable, technologists feel comfortable. But it's really hard with a screening study, right? Because you have to sort of implement it to everybody. So I sort of feel for the commenter who said that, because trying to get the radiologist back on board sometimes can be difficult, because in general, I think we're a little bit risk averse. We know that if we miss something, it can
come back and bite you.
Really it's
for many
sometimes,
reasons.
huh?
Come back and bite you for many reasons.
For many reasons, we really worry about our patients. And so we want to make sure that, I think in general, we're a little bit conservative and moving forward, but also breast imaging, radiology in general is always going to have new technology. And so we have to learn to move forward. And so I think it's interesting how we all have had some different experiences, and, there's no one good way. I think, Nina, how would you, if somebody was starting to get synthetics on, how would you advise them to get people comfortable with it? Do you think that it's a year or a couple of months of doing synthetics with 2Ds and then just everybody on board? Or
I don't think it's sort of, for me, it's kind of like, when's the right time to buy a house, get married, pick a new job? Like, there is never going to be the right time, but you're either the dive into the water person or you're the tiptoe in. I just like to dive right in. And so I did do the year. That was I said, okay, I get that. We'll look at it for a year, but if at the end of a year, no one can come up with a good reason why we can't go forward, then we're not going to tiptoe anymore. And that worked for us. I think if we had tiptoed in, we'd still be arguing about it to this day. I don't think there's no way you're ever we have a big group. We have 30 breast imagers. So I don't think we ever would have reached consensus if somebody hadn't been brave enough to be like, nope, that's it. We're done.
That's it. Yeah. I think for me, that sometimes when I'm busy, I tend to just go with what I'm comfortable with. So even if there was, for those 2 or 3 years, if there was a if there was a synthetic mammogram and a 2D, and I just felt like, oh, I gotta, I'm have a lot of work to do, I'm busy, I'll learn that later. What I really probably wish I would have done, and I advise anybody else, is to really look at that new technology first, that slab, the synthetic mammography first, and then look at your 2D. And you guys probably all are shaking your heads like, yeah, that's what you're supposed to do. Why didn't you do that? I think you just get busy, and then all of a sudden a year has gone by, and I didn't really use that as my first my first look, if that makes sense.
My advice to people, and this is kind of, when we were kind of going through the trial phase, we did, I think it was either 6 months or a year, where we did, okay, we're going to do the combo for everything. And then we basically did that. We're like, after a year, same thing you did with at your place, Nina. I mean, what we were doing, I remember talking about this in a meeting, was, okay, if you find something, if you have a callback, go back and look at the 2D and see, would it have changed? If you notice something on a screener, go back and look at just the 2D or just the synthetic and say, would I have missed this if I just be honest with yourself? Okay. Would not having the 2D with this combo view, would it have made a difference? And the answer that we kind of came up with, that everyone kind of came up with, was no. I mean, it was, there was no real big cases where it was like, oh, see this cancer? I would have missed this if I wouldn't have had the 2D. I can't remember someone, maybe there might have been 1 or 2 that I'm not aware of in our group, but I don't remember any big.
But isn't that why all this kind of stuff needs to get decided by evidence-based medicine rather than by people's anecdotal experience? You can't let your anecdotal experience make these kinds of decisions. You have to believe the people that have done the big trials and have said that, that they're equivalent, or that some things about one are better and some things about the other are better, but that on the balance, they're equivalent. If you're going to let people's anecdotal experience guide you towards new technology, you're never going to get.
That's not science. Yeah.
And at the end of the day, that should give us comfort, knowing that it's been tested, tried and true. These big trials are, out there to support us to be able to make that leap into new technology. We're not just doing it willy-nilly. It's someone has actually looked at it and saw that, okay, this is a good thing. It's, studies have shown that you're not going to, once you jump in, you're not going to be a worse breast imager.
And I think that's part of, the buy-in, that you get from some radiologists, because everybody has a group that they're working with, and there'll be people who are quicker to, to get onto new technology, and other people who want to hold on to some of that old technology. But you use that data, and also sometimes just also saying, well, we talked to people at this place and this place, and some of those, sometimes that helps too, is when people realize, well, everybody else is doing it, or this place is doing it. So certainly they, do quality work. And so we can too. So it's just a different way of presenting that data, I think. If I had to give up 2D, I would feel like quitting breast imaging. I
Don't
very
quit,
much
Zippy Mac. Do not
but I
quit,
haven't
please.
seen much of the newer versions. Yes, the newer versions, I really are much better.
They're fantastic.
Yeah.
Still, they're not equal yet, but someday they will be, right?
Okay, so we talked about this a little bit before the show started, but I was there for the transition from film screen to digital. People did not like it. Okay, there were major fights in my group at that time that the resolution was better on film screen, and we were crazy to be switching to digital. So, I think at every step along the way, there's positives and negatives about all these things, but I think you have to put the patient first when you're making these decisions. And I think that's what I've used to guide my decision making as a leader of our group, is like, what's going to be best for the patient. And I totally understand the person who made that comment that they don't want to be a breast imager if they have to do this, but I tried to always be guided by what's going to be the best for the patient. So when it comes to this topic, it was, shouldn't I be guided by the fact that we're cutting everybody's radiation dose in half over their lifetime? Like, that felt like the better thing to be guided by. So please don't quit breast imaging, because there's not enough breast imagers in the world. Like, please, the person who made that comment, don't go away.
And technology will get better, right? I mean, we've seen such a huge jump, in my opinion, from the early generation synthetic mammos to what we have now. And it's just been a short period of time. So I think, the vendors are doing a great job in terms of advancing technology. And I know that there's going to be a day when it's basically the same, So yes, please don't quit breast imaging. Do you guys have patients that request synthetic mammography? Did you guys do any type of patient education? Let them know that they're getting half the radiation dose, or does that then shed light on the fact that they were getting more later? I mean, what?
I don't recall us advertising the fact that we're just doing synthetics.
I had one patient complain. But when we were doing both, because we were a mixed shop, one patient complained. I don't know how she even knew, but she complained that she was getting a 2D and a 3D, and about the radiation dose.
It does take a little bit longer.
It might be just that she had it somewhere else, and she was coming, because most patients who had been with us for a while, they had no idea. And so one patient out of tens of thousands. But it wasn't advertised. I know there was a group across town that was advertising it. And so what did
they say? They just said
lower radiation,
less radiation, same.
Yeah.
Okay.
Yeah. Mm-hmm. So faster, more comfortable, lower radiation dose.
Faster. Yeah. I mean, it is a little bit faster. The breath hold obviously is shorter because of that. So
I have a cautionary tale, kind of jumping back. It doesn't deal necessarily with the synthetic, but when I was in West Virginia for our implementation of tomosynthesis, we were doing a lot of, I wasn't involved. I was just a, junior resident, but as an organization, they were doing a lot of, outreach, talking about how Tomo was important and whatnot. There was a private practice surgery group who was advising their patients to not go to our breast center because they wanted to do full CTs of the chest on everybody. That was like, and it was like, they want to do CTs on everybody every year. You imagine the radiation exposure. And like, I remember hearing, I wasn't part of any of these meetings, but it was a big fight to get them to kind of come down from that opinion, to like explain to them that these aren't CTs of the chest. This is tomosynthesis. Yes, we get slices. I think they hear slices, or I don't know. I wasn't privy to those conversations, but I remember hearing about that thinking, oh my gosh, really? Like, it was
So much
crazy.
misinformation. Yeah. And that's the problem, right? When that gets out there and that's the first thing that a patient thinks of, then that sort of stays there, which is, again, it's important for us to be out there talking to patients. I know, Nina, you do a lot of patient outreach too. And so that's patient education is important so that we don't get misinformation out there.
I think Matt's point about referring provider education is also crucial, because I'm still getting questions about what's Tomo. I still have certain, primary care docs and OB-GYN docs in town who are a little bit old school, and they tell their patients, you don't need that.
Yes.
Because they don't really understand it. And so I think it's not just about informing our patients, you need this. It's also about, reaching out to our colleagues in other areas and saying, hey, can we talk about this? And, I think your patients could really benefit, and it could save them, time, it could save them money, it could increase our ability to find their cancers at earlier stages. Because I mean, not that I blame any of them. They are experts in their own individual fields, and this is something on the periphery for them. But I think if we could do a better job of reaching out to our clinical partners, that could also be helpful.
Did you reach out to any surgeons when you switched over to synthetic mammography? Because I know that a lot of surgeons are comfortable looking at, I'm not saying interpret, but they're familiar with looking at mammograms, and then this would be something that looks different. Certainly clips, sometimes the shape of clips can be a little bit, harder to see. Has anybody got any feedback from surgeons or any providers that noticed the difference between synthetic mammography and have any questions? Or
no, but it's interesting you should bring up the thing about the clips. So we take our 2D, our loc views and our post biopsy clip views 2D.
That's good. That's good to know. So
we do pretty much every kind of wireless technology for localization where I am. There isn't a vendor that makes a wireless device that I'm not putting in. Sometimes all 4 or 5 of them in a day. But whether it's a wireless loc or a biopsy clip, we always do those 2D, because I do find surgeons, especially in the OR, have a hard time recognizing the difference between the clips.
Is there anything else that you guys do, like like extensive disease, new patients, anything? Nope. You guys just diagnostics, calcs, obviously the mag views.
Mag views, yeah.
But then if you do the mag views and you do a true lateral, is your true lateral synthetic?
No, mag views have to be 2D.
I mean, the full. Do you guys do a full ML?
I do a full 90, and it's 2D.
And it's 2D. Okay. All right. So for diagnostics for calcs, for looking for a clip, but not like for extensive disease or maybe neoadjuvant chemotherapy response.
When we were making the transition, we did our diagnostics for extensive disease. Like if somebody had a BI-RADS 5, they were getting called back for on their screen. We did a 2D looking for calcs, because we wanted to make sure that we weren't missing anything. And, we did not feel comfortable that we would be able to see everything we needed, because sometimes those teeny tiny subtle little things far away from that mass are crucial. So that was something we did in the transition.
I will find as time has gone on, I'm using the Tomo slices more and more for looking for calcs. And, and I don't know about you guys, and I guess we'll talk about it later, but I'm also using Tomo for biopsy for calcs now too. Like, I think when we first made the transition, we felt like all the evaluation for calcs had to be off the 2D view, because that was like what we were used to. But as time has gone on, we've been like, no, you can actually evaluate calcs on the Tomo slices.
Seeing the distribution of them, right?
And even the morphology of them.
Yeah.
Even the morphology of them.
I assume really precise with your scrolling.
Yeah. For implants, you guys are doing 2D, at least for the non-implant displaced views?
Yes.
So 2D for the non-implant displaced views, 3D for the implant displaced views.
Correct.
So that's like one other thing that we do 2D.
Yeah. Okay, so the next topic I'd like to talk about is slabs versus slices. So obviously when we implemented tomosynthesis, it really did increase interpretation time. There were millimeter slice thick slices, and it takes a while to get through a full Tomo study. So in the last few years, vendors have come up with making thicker slabs. So instead of 1 millimeter slices, for example, one vendor would use a 6 millimeter slice with 3 millimeters of overlap. And this decreases the number of images that breast imagers have to look at, and also decreases interpretation time. So question to the panel, do you guys use slabs, or I guess it would be thick slices, whichever one you want to call it? I think that they're vendor specific, but do you use the thin 1 millimeter slices or slabs?
I love this topic. I love this question and topic because we literally just rolled out slabs at one site to trial it to see how we like it.
Okay.
So by and large, we use the 1 millimeter slices for Tomo still. But it was implemented last week when I was on vacation, and I came back and I'm reading. I'm like, oh, we have slices, or we have slabs on something, but we're still doing the 1 millimeter. So it's kind of like a trial thing. So
yes.
We're still doing the 1 millimeter, but then we also have slabs available as well. And I like it. I've only spent 3 days doing it. So it's like you're seeing what I'm feeling right at the initial start of it. I like it. I don't know any of my numbers comparatively, but I think the data is out there that supports it.
Yeah, I mean, as a place that had Tomo really early, I have a lot of machines, and we're converting them all over to the high resolution detectors. And what we found, we read off packs. I don't know what you guys read off of, but we couldn't. When we switched to the high resolution detectors, as we switch each machine over to the high res, and we're probably about a third of our machines now are on the high res, and by the end of this year, it'll be more than 50%, probably 100 by mid-year next year. We couldn't read slices anymore. Like the amount of data coming over from those high res detectors and slices was killing our packs, and not just
slowing everything down
for our entire department. Like it was basically like all the energy of the entire department being sucked up by the breast imaging division. So as I convert over, we're reading slabs, no slices off anything that's coming off the new machines that have the high res detectors.
How about you guys, Rachel?
Yeah, I've kind of been a pendulum with it. Very, very early slabs, I hated them. I thought I couldn't see anything with them. They were awful. And so then I went back to the tiny slices, but we were reading off packs and it was crashing, and that was awful. But the newer versions, I like the slabs. My wrist really likes the slabs because I'm a scroller. Even though my husband keeps buying me all the fancy mice so I don't have to scroll, I'm a scroller. And I'm coming back around to them. Yeah.
Yeah, I think the transition from slices to slabs has been, for me, much easier than 2D to synthetic mammography. So if anybody's listening and they think that the slab, in my opinion, that transition is going to be hard, I think you're going to be surprised. Okay. So somebody is asking thin only, and have asked my sites who were doing slabs before I arrived to stop. Why look at both? If your system is optimized, then thin slices should scroll quickly. Well, I mean, sometimes it does decrease interpretation time. And we have to think about, this is my opinion, is that, we also have to think about repetitive injury, eye strain. It can be really hard if you have to look at, a whole day of reading Tomo. I think it can really decrease our interpretation time and hopefully prevent some injuries, which I think if you spend 30, 40 years in radiology and don't pay attention to that, it's very likely to occur. And I really wish we would talk about that more.
I've been sending all the larger patients. I've been sending all the larger patients into the room that we're doing the slabs on. Like,
because you're not like, they're fatty, right? Fatty breasts. So
if
you're gonna compress to greater than 6 or 7 centimeters, you're going into the slabs. Yeah.
Just to confirm this from my own knowledge, the slabs, obviously it's fewer images. Is it? I assume it's better on the data storage as well.
Oh yeah, the data storage. So not only is it the speed, the data storage is also less.
Yeah. And so
that wasn't really my primary thing. I don't care about data storage. That's somebody else's problem, but the speed is a huge problem.
Absolutely. Yeah. So we were having issues when we started doing the enhanced C views and whatnot, because the images were so high. We actually went in the other direction, and we got our IT to get hundreds of memory boxes or whatnot. They put them in a big closet. And they boosted the memory, which seemed to work. Whatever they did, I'm not an IT person, but I just remember it was a big thing. We had to buy a lot of memory because we were, converting to the enhanced C view.
Do you guys save your prior Tomo slices?
Mm-hmm.
Okay. Yeah.
And that gets to the if of the commenter's comment. If you're optimized, well, if you're caching all of those Tomo slices for, however many years, you will not be optimized, or you're gonna have to spend a ton of money in order to be optimized. And so I think that's something that especially smaller practices really struggle with, because there's a cost associated with all of that.
Yeah,
I think it goes back to your point, Nina, about what's right for the patient and whatnot. And so if studies out there are showing that slabs have no detriment versus slices, then, it should be practice specific. If it works for your practice, then do it. If there's something that shows that slabs are beneficial to the patient for whatever reason, I don't know what the current data is, just because it's kind of a newer thing. But, I think we should let, patient care dictate our approach to these things.
But I think also not just patient care. I think in this situation, I'm going to go back a little bit in what I said. I do think we have to think about ourselves. Like, I think if it's equivalent for the patient, but for the radiologist's health and well-being, it's going to be better. Like, that's not zero consideration. Like,
it's like on an airplane, you got to put on your mask before you put on your kid's mask. Like,
it's one thing to have it be personal preference. Personal preference, I'm plus minus on personal preference. But your actual physical health and well-being, I don't know. That seems like something that's worth considering when it comes to this kind of stuff.
Yeah, burnout is a problem, right? And we have a shortage of breast imagers, and volume is only going to keep going up. And so we have to make sure that that we're around to take care of patients. So I think if studies are showing that it's equivalent, it's the right thing to do, probably. So hopefully people will get on board. I think it does help. We did a trial. I think that we maybe are a little bit conservative where we sent both of them. But now we in general just have slabs. And then if the radiologist feels that they might want those 1 millimeters, we can call and ask the technologist to send those 1 millimeter slabs before we decide to call the patient back or not. So I think we're a little bit in the transition, but I think I'm sort of liking slabs a little bit more than synthetic mammography, but we'll all eventually get on board. Okay, so I think that we have a little time. I did want to touch on Tomo biopsy if we can. So once we added on tomosynthesis, we were able to see some lesions that could only be detected on tomo slices and not on 2D. And so the ability to biopsy under tomosynthesis came about, and that was introduced in about 2013. And I think there was a little bit of an uptick in some, architectural distortion that were radial scars, but overall, I think it was people really, really liked to be able to do a biopsy. I think it's terrible to see something and not have the ability to biopsy it. So I think when we did that transition, there was a very short period of time where we just had Tomo and not a true Tomo biopsy capabilities. And I did not feel comfortable in that space right there. But has Tomo biopsy replaced 2D biopsy in your practice? Do you guys do those 2D stereo views for anything anymore?
I can't remember the last time I did. It's been over a year. We still have the capability. I mean, some of my partners do, but yeah, everything that I do, I'll do how I do it. My protocol is I'll do a 2D to set up to make sure that I'm in the right position. And if I see the lesion or if I see the calx or whatnot, then I'll Tomo through. And, that helps me look for vessels, helps me look to make sure I'm direct. And I thought when I first started adopting it for calx, because, it was originally for, asymmetries and whatnot. And when I started getting, fancy and doing it for calx, I thought that I was more accurate. And I was like, okay, I'm never going back to the stereo views.
The only time I switch back to the stereo views is if it turns out I'm not that happy with the needle position, right? Because it can be really hard to figure out your needle position in Tomo. You have so much artifact coming off the needle itself that stereo views can sometimes be nice for for your needle position. So I do sometimes shift back to the stereo views mid procedure if I'm trying to get a better idea of my needle position.
So I mean, to clarify, I do that 100%. So actually the only time I do a Tomo is when I target. And then after that, I do the stereo views.
So I'm not going to lie. If any of my techs are watching or anybody who works with me, my typical biopsy is 3 exposures. I do a Tomo sweep. I basically position the needle. I don't take a post-fire picture, and I take a picture again for the clip. And that's
with the traditional Tomo, you can't see anything post-fire. You can't see anything post-fire, and so
what's the point of the post-fire? You can't see anything.
Yeah. But if you have, does anybody utilize the lateral arm, which basically makes it so that you don't have that artifact? Then do you take a post with the lateral arm, or
with the lateral arm, we do. I like the lateral arm for subtle architectural distortions for the same reason. Like, it's really hard to see that thing once you get the needle in. But if you come in lateral arm, now you have the distortion in front of you and you can see it really well. So I use it. I never use it for calcs usually, but I do use it for that.
Yeah, I use it for calcs too. I really do like to use the lateral arm, but I find it difficult to numb in the central part of the breast. And so I did a few where maybe I wasn't able to get the patient as numb as, as probably they should have been. And so if it's in the central portion of the breast, I try not to use the lateral arm. I don't know if anybody else has that.
I think hemostasis is an issue too. Like, I was trying to love it, but like, I'm that person that really likes to be holding a lot of pressure afterwards. And like, you can't hold pressure against nothing with that, and so I don't really, I love being able to like press down on the breast right towards the detector and have, the back pressure of that when you're done.
Yeah, that's a good point. Yeah. Rachel, what about your experience with Tomo biopsy?
I love it. It's my favorite thing. I was asking for it for almost 2 years before we finally got it, and it felt like Christmas morning. And it's great because we were sending all these people to surgery for these distortions, and so it cut our surgical rate. It's faster. I use it for everything I can because I feel like it's less exposure. It speeds up my time. I do time myself to see if I can like beat my time, and I think it's great. I'm actually transitioning into a new job where we don't have it. I'm like, okay, how am I going to get one?
On the table.
Yes. Well, I'm only a few days in, but yes, because it is my absolute favorite thing. I just love it. I actually do love the lateral arm. And we actually would lay patients down after we do the procedure upright. We would lay patients down and kind of oblique them to get that pressure. Because I agree. I really do like putting a ton of pressure cranking on there. I feel like I am so much more accurate with that lateral arm. And when they were showing it to me, I was like, oh, I'm never going to use that. And then it's like my favorite approach at this point.
Yeah, we have a prone lateral arm table, which is,
okay.
which, I think we can do it. You can do it upright as well, but we have just the Tomo biopsy and upright. Do you guys have both the upright and prone, and do you prefer one, or for certain cases, do you use one versus the other?
We have
prone
both.
versus upright. Matt, do you send everybody in the prone, or do you use upright more often?
So we have one prone table at our system, and the purpose for that was we wanted at least the ability to do prone.
Oh my God, exactly. Yeah. That's exactly my answer. That's exactly what we have.
Yeah, so it's great. So like if there's specific case, if it's like really posterior or something, we'll actually put in the dictation, would biopsy on a prone table. But that doesn't happen terribly often. But if the patient, as you're going over the procedure, talking to the patient about the biopsy, and when you're doing the diagnostic, I don't want to sit up, I might faint, or if they have an admitted, this predisposition to fainting or having, lightheadedness or whatnot, then we'll recommend doing them on the prone.
That's interesting. We have the exact opposite. We do almost all of it on the prone, and then certain cases, I think for me, I'm always, I don't really want them to see the needle. It's not always. So do you guys just turn? You always turn
all the techs are trained that we actually have techs put paper in front of their eyes.
You do. Okay. Yeah. I do almost all of it on the prone table. And then occasionally, if the patient has back pain, or they can't be on the table for other reasons, we'll do an upright. But I love the prone table. You guys don't have the same. Everybody's got different.
You know what? Here's why I love the upright McFarland.
Yeah,
from
I
the
don't know.
tech's point of view. The positioning is so much easier for them because it's the exact same positioning as the original Mamo. So like there's no time loss. Like doing an upright stereo is like doing a loc. Like you don't have to leave the room. You're gonna get the positioning right the very first time. And so you just consent them, take the picture and go. When I used to do a lot of stuff on prone, you know, the tech would be futzing around sometimes for 10 or 15 minutes trying to get the area in the window. That like never happens upright. Upright, they're going to get it the first shot, like almost every time.
So I got a few things to say about the prone versus the upright. I don't really prefer one over the other from just a procedural standpoint. One of the just system-based downsides of having a prone is that's the only thing you can do in that room. And so, you know, it's a big table, it's a big machine, and it's you have to have a big room for it. So it takes up a lot of real estate. So that's one of the reasons we don't have it at all of our sites. But on the other side of the coin too, when I'm talking to patients, I found that when I, present to them that they need to have a stereotactic guided breast biopsy, sometimes, not often, but sometimes the patient, oh, is that the one where I got to lay down, my breast goes through a hole? Because, 10, 15 years ago, things were a little bit less streamlined than they are today. We didn't have Tomo biopsies and whatnot. And so patients have bad experiences. It probably wasn't from being prone, but they just associate that time. And now, we do it differently now. We do it differently. We sit you up. Oh, I said, oh, that's so much better. Okay.
And then 5 years from now, they're going to be like, is that when I had to sit upright?
Well, yeah, absolutely.
No, we have a table and you lay down. So just changing it up on patients. Yeah.
But sometimes patients just having a change, saying we do things differently. I'm not necessarily saying it's better, but we're sitting you up now. Oh, okay, good. I don't have to lay down anymore. I can just sit there. Okay. I don't know. It gives some patients some comfort.
Yeah, and I think some patients decrease their anxiety level because if they're sitting up, they can have a conversation.
Sure.
When you're laying on a table, it's hard to look at somebody and to have them really interacting with you. But I've had patients just chatting away with our technologist. We have one technologist who just sits in front of them and engages them in conversation, and we're done before they even notice. So I think it can help in that respect, and just making it feel like it's not as big a deal because it's familiar to them. The positioning is familiar. And usually we have the tech who did their biopsy come in and talk to them or who did their screen. So they know that tech, and it helps them kind of get through it a little bit better.
So for people, if they're listening, it probably makes a lot of sense to start with an upright, or to have more upright than prone tables.
I'm not knocking them. I'll be honest. I'm not knocking a prone. I get good biopsies on my prone table when I use it. But from a logistics standpoint, you can do a lot more by putting an upright table in, because you can do screens and diagnostics on that machine as well.
Sure. Yeah. We have our contrast mammo, the copper filter on our upright, the same machine, because hopefully someday we'll be able to do biopsy capabilities in that room.
But here's a question you didn't ask. Are you doing Tomo on your contrast cases?
You know what? We tried to do that. That took a long time for the images to come over. And so what I do is, if I have Tomo already on that patient, I do 2D contrast mammo, because it's not like each one of those slices is the recombined view. Do you know what I mean? It's like a low energy and high energy, like the subtraction view.
Yeah, it's like 3 views.
Yeah.
We're doing it. We're doing it routinely on everybody that we do contrast on. So we've got the low energy, the high energy, and the Tomo slices.
Because it's the same positioning. Well, a lot of times we do it as a diagnostic study, so we have already that screen. And so I just wasn't sure about it. But sometimes we do if we think we need it. But I don't know that it helps me as much with that.
It's good for the biopsy. So until we get to the point that the whole contrast biopsy situation has smoothed itself out a little bit more, it's nice to have the Tomo slices there, because sometimes you can find that thing on Tomo, and now you're going to be able to do the biopsy as a Tomo biopsy.
That's a really good point. We had a commenter who said that they love their upright table too. So maybe you guys have convinced me to go back and try that a little bit more and see how that works. We just have a few more minutes. Do you guys have any last minute comments, any tips or advice to anybody who's listening who might be making that transition over to synthetic mammography slabs? We just got a last minute comment. Let me just go through all of your guys's and then we'll see if we can get to this. How are you choosing patients for?
That might be a whole nother webinar.
Yeah, say love the interactions.
That's for next week. That's actually a perfect transition. Let's talk about, let's do this, and then I can help that person with the webinar next week. Yeah. Any last minute tips and advice?
Keep trying. My initial reaction is very rarely what I end up thinking after I've kind of gone through and spent some time with it. So even if you hate something at first, give it a fair shot, keep trying. And as technology evolves, what you used to hate might be your new favorite thing.
Yeah, true. Yeah, Nina?
Yeah, no, I agree. I think, part of what makes this field fun is that I can't believe the things that I've seen in my time as a breast imager. And part of what makes it fun is this new technology. So, if you look at it as something kind of exciting for you and potentially good for your patients, rather than just a struggle of something new to get used to, maybe it'll feel like a more positive development.
Yeah. And I'll add, just let the data guide you. I mean, we talked about that, but when these new technologies come out, they're not just haphazardly, put out there without being vetted first with peer-reviewed data. And, so it's not like the breast community is picking on you by making you do something new. We're trying to evolve as a subspecialty and make things better.
Yeah. Always forward, never back. Right. Okay, well, thank you guys. This has been a great discussion. I really appreciate you guys being on this panel. Next week, we have a really great topic, a general topic that would be great for patients or providers. Dense breasts, what does your institution do? And then 2 weeks from now, I know that we had a commenter that was asking about contrast enhanced mammography. So, they should tune in 2 weeks from now on August 17th when I don't know the exact title, but it's basically going to be about the new technology and advances in breast
emerging
imaging.
Topics in breast imaging.
Thank you. And that's going to be a wonderful topic as well. So hopefully people will tune in for our last two.
And I guarantee you contrast enhanced mammography will be discussed in detail.
Yep. Okay. All right. Well, thank you guys. We'll see you next week.
Thank you, Mifa. Appreciate it.